Morning, George. It's Tuesday morning.
It was a great time. We saw you do the speaker network speaking, and then we hung out. So today we have a excellent physician, Dr. Jordan Gitlin. He's a pediatric urologist, and the topic of discussion for today is going to be in our Day in a Life series. So a day in the life of a pediatric urologist. Let's see what it's all about. Take it
Dr.
away.
Git- Dr. Gitlin is the chief pediatric urologist at NYU Langone, Long Island. He's also the managing partner at Pediatric Urology Associates and has published multiple scholarly articles and book chapters. He's been mentor to numerous pediatricians, medical students, urology residents, and urology fellows in pediatric urology. Dr. Gitlin, it's an honor and a pleasure to welcome you to the show.
Thank you so much. It's my pleasure and honor to be with you guys. Hope you had a nice time in Long Island.
It was a lot of fun.
It
The
was like a
perfect
frat
time of
house
year.
week. It was like in a frat house for a week.
Uh,
Yeah.
we always start by asking you what inspired you to become, in your case, a pediatric urologist.
Yeah, it's a great question. It's one I think about. I actually have my oldest daughter is in medical school now, and so we talk about what you'll be, and she frequently asks me, "How did you decide on pediatric urology?" When I was in medical school, I think for all of us when we were in med school, it was a little different. We didn't have access to the internet. We didn't have immediate answers to all the questions we wanted to know. And so I think for most of us in medical school, you have to make a decision. Do I want to be in the operating room a good chunk of my day, or do I not want to be in the operating room? And from the minute I started my rotations on surgery, I just loved the technical aspect of surgery and being in the operating room. For a year or so in medical school, I thought I would be a pediatric surgeon. And I loved operating, whatever it was. The one thing back then, this was probably the early mid 90s or so. It was before a lot of the regulations came about with surgery residents. I just felt that every general surgeon, not pediatric surgeon, but every general surgeon I met was not happy they were. It was so exhausting and so brutal. And I remember speaking with a few of my housemates, probably the end of our third year. I love surgery. I don't think I want to do general surgery. I really don't know what to do. And a friend of mine was on a urology rotation. And she said to me, "I think you would love urology." And so I rotated it, did a urology rotation at our school. And then I actually had a relative who lived in Philadelphia. So I went to Philly to do an away elective and had the opportunity to spend 2 weeks at Children's Hospital of Philadelphia. And when I met, that was like at that time, that was the mecca for pediatric urology. The giants of pediatric urology there were there. And within the first day of being there, being in the operating room and meeting these men and women, I was like, this is it. This is where I want to be. And that kind of just set me on the course. And I did a urology residency at NYU. And then I went out to Indiana to Riley Children's Hospital to do my fellowship. And that was just an incredible experience. My mentor would say to me every day, he'd look at me, he'd say, "You're like a kid in a candy shop." And it was like every day it was a different case. And the unique thing about practicing in the Midwest and a place like Riley is that you take care of every pediatric issue in the entire state and the surrounding states that when I first left New York, I didn't know the surrounding states, but I came to learn them quickly and really loved my time in Indianapolis.
What does your typical day look like?
Yeah, I look at my day, there's so many facets. I mean, I'll comment on the medical part of it, but like George was talking about his barbecuing for his boys and his house being the center for what is it, the oil crew, George?
Oil gang.
The oil
Yeah,
gang.
yeah.
I see so many aspects of my life, father, husband, parent, child to my parents now in the generation we're in. And of course, a urologist. And I think for all of us, it's funny, sometimes I come across people who are like, "Oh, everybody I meet in medicine's miserable, and I can't believe you let your daughter go into medicine." I think what the three of us get to do, and all of us in medicine, is just really, I feel like we're blessed. We're lucky to do what we do, right? We're lucky to take care of patients. We're lucky to have intimate conversations with our patients and our families. And on a day-to-day basis, for me, it's totally unique and totally different. So I would say for me, my days, my typical day, usually I like to talk about wellness. I try to start out with some sort of exercise, right? Keep my my brain and my body. And then my days are typically split up between either being in the office or being in the operating room.
We get students that come into the office, like the student that we have in common, Spencer.
Yeah.
That boy has to be the most determined person I've ever met in my life. He has a list of things and places and rotations. Everything is urology, 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 which is great if he gets it.
Yeah.
These kids are put through so much. And I think that's where a lot of us senior physicians, where we come around, we say, why would you let your kid go through all this?
Mhm.
I think the end result of becoming a urologist, a pediatric urologist especially, is a good thing.
Yeah.
You have to work hard.
All of us, right? None of us got here. You guys didn't, this podcast didn't come easy. You worked hard for it. Both of you, your residencies, you worked hard. For me, I mean, I worked super hard, and I actually continue to work very hard. But I guess the thing I feel lucky about is I really do enjoy it. And so I guess for me, the typical day, I see myself as I'm always teaching somebody, right? I'm always teaching and I'm always learning and teaching. And whether that's for students like Spencer, and I'm lucky I have a lot of students that rotate with me, or whether it's my patients who I'm explaining a complex problem with them. And I always say I try to paint with big strokes and take a complex issue and make it simple. Or whether it's, I thought I went into a room and I had a preconceived notion of what the patient needed, and been doing this for 20 plus years, and sometimes I'm wrong and I learned something. So I think that's, to me, that's the fun of it. You're always learning, you're always teaching. And that part of I really made up. But I would say a typical day, again, broken up into two aspects, right? So there's my clinic days where I'm seeing patients in the office. And those days are great, right? Because it's a different pace, and I'll see many patients in the office, and some patients are very simple. A lot of times it's a parent coming to me, they're concerned. We deal with my child wets the bed, and it's, what are the things we can do and how can we work that up, reassure them they're going to be okay. And a lot of times that's by doing a good exam, an ultrasound, talking them through, letting them know it's a common issue, and giving them some simple treatments and going to the complex. And then a lot of the stuff we see is surgical, right? We operated on him. This was a 14-year-old boy, insulin-dependent diabetic, whose mom was actually a physician in Egypt. And yeah, brilliant woman, manages his diabetes. Probably she had the app, so she's checking his sugars 24/7, monitoring him. And he had come to us with 2 years of intermittent abdominal pain and vomiting. And someone decided to get an ultrasound during one of these episodes, and it showed very hydronephrotic, blown out kidney consistent with a UPJ obstruction.
Wow.
And we did a great robotic surgery on him, and that child did well. So that's someone who, from seeing him in the clinic, meeting the family, talking it through, working it up, doing follow-ups of each exam, video visits, getting to know them, diagrams, teaching them, showing them the problem, to actually getting to fix the problem. In the old days, it would be a big incision. You're in there with your hands. Now it's these tiny little incisions doing this wild robotic surgery.
Let me interrupt you for a minute,
Yeah.
right? Because I trained before the Da Vinci robot and invasive surgery. Everything was a gallbladder surgery. They had this huge thing that you pull. The medical student's job was to pull the liver back while the surgeon took the gallbladder out. Remember those days?
Boy,
So do you go like through the belly button and blow it up? Is that how your approach with this surgery?
Yeah. So we do a fair amount of robotic surgery for things like UPJ obstructions, and we take care of a lot of kids that have like ectopic ureters or duplicated kidneys that drain into the wrong spot. And so, yeah, so in the past, you would make a big flank incision and they'd be in the hospital 3 or 4 days, could barely move. Every time they took a breath, their intercostal muscles were killing them. Now it's 4, 5 to 8 millimeter incisions. You start right in the belly button, and that's how we get into the peritoneum, put a little trocar in, insufflate the abdomen. And so now they're all blown up, and then we roll them on the side so all the bowel drops down. And then we come down and we're looking right at the kidney. And the way I describe it is laparoscopic surgery is great. It's these little incisions that lets you work inside. But laparoscopic surgery, remember the dance, the robot, where you're moving like this and your arms can move side to side and up and down. That's laparoscopic surgery. What the Da Vinci robot has done is it's taken this movement, and now literally your hands inside can move like this. So if you watch the robotic surgeon, it enables us to be able to hold things, to dissect, literally like your hands are. So it's an incredible technology. And to take it down to be able to do it in children is just phenomenal also. And we're pushing the limits. And I think the youngest pyeloplasty we've done in a child is about 14 months old. Yeah.
Was it bizarre at first? Because when you went in there, you put your hands in there, you felt
Yes.
how the patient was warm, you were seeing whether oxygenated or not, because you were seeing the blood in your
Yes.
hand, if it was bright red or it was chocolate color, and then you looked at it and you know, you got a problem.
Yeah,
Was it,
chocolate's mad, right?
you know, what the problem is, but blood's not supposed to look like chocolate. Was it, did it take some time to get used to losing that feeling and then looking at the screen like you're
Yeah.
playing a video game?
It's actually a great question, right? So our generation of physicians, we all trained, you said, when everything was open surgery. You're right, like gallbladder, giant incision. Your job is measured, retract, retract. And so what's interesting is that now most surgical specialists, whether it's a general surgeon, a urologist, OBGYN, 90+% of what they do is robotic. So the men and women training now, they don't really have those open skills. But for someone like me to make that transition was definitely challenging, because you're right, like you had that tactile sense. And if you ever got into trouble, if there was red or anything, put your finger on it, gather your thoughts and figure out what was going on. And now it's a whole different skill set. So it definitely took a while. And what's interesting is that the residents, they love working with us on pediatrics, because still a lot of what we do is open tactile surgery, right? So a lot of the groin surgeries, it's a hernia or an orchiopexy or hypospadias surgery, or even some of our bladder surgeries, it's still, a lot of it's still open surgery. And I'm always reminding them, like, hey guys, like, this is open. It's different than robotic, or it's different than endoscopic. Yeah, it was definitely a big transition.
What are your thoughts on the new generation of kids that see surgery or learn surgery as a video game? What happens if that video game breaks and you're not around?
Yeah, it's really a problem. And I think that, that our newer colleagues, they do struggle with that. And it's something, luckily, on one hand, they don't see it that much, because thank goodness, robotic surgery, and we're getting better and better technically. But it is something, I guess, they do get some open experience. And it's something we really talk about a lot with them and try to prepare them. Like, okay, we're doing that. If you were to get into trouble, what would your incision be? And what would your first move be? And try to do the drill in the brain, in their mind, so they would know what to do. But yeah, it's a potential problem.
Yeah, I guess for Herb, it's almost like back in the day when we used to do paper charts, and then you come to the office and there's no senior physician in the office and the internet goes down. The complete machine just stands still because nobody knows how to write.
Yeah, but it's time. It's
Yeah, we have time.
someone's got a bleeder you can't control,
I know.
and you can from what I saw from surgeons, I particularly did not like surgery, and I'm a total jerk about it. I just think that surgery, for the most part, is a failure of medicine. When you can't fix it, you yank it out. But that's very narrow-minded. There's lots of things that surgeons fix, and you're wonderful people. But what I saw as a medical student was there were some people, for me, it was mostly men surgeons, who were not very good doctors. They weren't good at the thinking science, but my God, they were artists.
Yeah.
I had this guy that was just, everything was a joke to him. He was an OB-GYN. He walked in, he would have salsa playing in the operating room. He would do the salsa dance with the nurses as he's getting gown, and he's like going like this and like that. He could take a baby out in 10 minutes. And then he go to the next room, still dancing, change over, take another baby out in 10 minutes. He never had a bad outcome. He was just, it was like watching a guitar player or this phenomenally gifted artist with his hands. And it was just nothing to him. It was just like a basketball player that he just does it, is not even thinking about what he's doing.
Yeah.
And I saw him say, I thought the woman was going to die. It was a C-section. She didn't want to come in because of the holidays, so she stayed in labor at home for 24 hours. When he opened that uterus, it was so thin that every time he put a stitch to close it up, it would hiss and the whole thing would start bleeding.
Wow.
And it was a
Wow.
young 20s. I'm like,
Yeah.
this was going to die. I'm
Wow.
gonna watch as an intern, a woman died in the
Oh my
outbreak
God.
from childbirth. And he pulled it. I don't know how he pulled it out. It was like a sewing machine. Didn't work. Did his. Do it again until he stopped the bleeding.
Yeah.
He was amazing. The woman OB-GYN had trained in the US and she had a fellowship in fallopian tube surgery.
Mhm.
No one wanted to operate with.
Hmm.
Every C-section was 45 minutes.
Yeah.
She was the most delicate, attention to every detail
Mhm.
person in the world. Phenomenal.
Mhm.
But she just couldn't pivot.
Right.
Everything had to be done because her expertise with fallopian tubes, she had to do a C-section. This was like, no, it's got to be done. Dab, stitch, dab, stitch.
Right.
No, that's not what we need. We need the baby out and we need to get the mom
Right.
off the table as fast as we can. So I can't imagine people who don't have that skill set in an
That's it.
emergency having the skill of that one surgeon that had done it so many times. He didn't think about it. He wasn't courteous about it.
Yeah.
But his hands were just magic.
Yeah. Those guys that have been doing it for so long, that's where you got the God complex in surgeons.
Right.
Because I remember there used to be a general surgeon out here, one of the very few pediatric surgeons back in the day, I won't mention his name, was the best surgeon. He would operate on anything. He would never be afraid. His bedside manner was the worst. We would call him in for an appendicitis before it was robotic and CAT scans and everything. His diagnoses were on the money each and every time. He says, look, if you want to get your kid better, he's the surgeon for you. Get over it. But that's not appropriate anymore these days.
You really need to find a balance. People, when they meet you, they want to like you. It's a whole combination. And I always say to the residents when they work with us, I say, you got here, you got to residency because you could take a test. You got into med school because you could take a test. When you got from med school to residency, you wrote a paper, you did a test. But now, whether it's pediatrics, whether it's peds urology, now you have to learn a trade. You have to learn the skill. And that part of that skill is how to talk to people, how to make them feel good, how to recognize when a patient comes to you, right? Kid with a fever, you have to recognize immediately. Is that something this kid's really sick and it's going to crap out, needs to go to the hospital? Or is it Tylenol, Motrin, and you're going to be fine? And it's the same, it's that trade that you don't learn it in a book, right? That's why you have to spend years and years doing it, being able to make those decisions.
Yeah, I have a very funny story about that because my nephew had two trigger thumbs. And I sent him to the pediatric orthopedic surgeon who's phenomenal at a children's in Fairfax, Michael Ring. And Michael Ring is a typical orthopedic surgeon. I talked to him before I sent my nephew. He goes, sounds like it, Herb. You know, we got to operate. I said, yeah, my sister's married to a radiologist. I'm sending them over. They're going to see you. This is great. Thank you. See you. Boom. Phone hangs up. He goes in, he walks in, he goes, oh, you're Herb's sister. Yes. Yeah, your kid's got a trigger thumb. My assistant will schedule you for the OR. Great to meet you. Say hi to Herb. Walk
Emotion.
She called me crying, right? This is such a bad human being. How could you send me that? Oh, wait, I think you're married to a radiologist. He makes plenty of money. Yes. And you're Catholic. You're not looking to get divorced. She said, no. I said, I didn't send you on a date. I send you someone will cut the kid open, fix it, and the thumb won't fall off and he won't get an infection. That's all you care about.
Right.
Whether he's nice, blonde, tall, short, Jewish, Catholic, Muslim, you don't care.
Right.
You just
Right.
care about a good outcome. So get over it.
With patient satisfaction.
No,
Right. Sure. Yeah.
And I have a bunch of questions for you because everything changes so fast.
Yeah.
The undescended rectile penis, testicle drives me nuts.
Yes.
Yeah.
We see a ton of kids, right? Yes, typical day, right? So typical day that when I'm in the clinic, I'm seeing kids with everything. That's a big thing I see, right? So I always say that you guys as pediatricians are at a disadvantage because when these boys come to you, let's say 4 or 5-year-old kid, they're nervous, they're tense. You guys have to check everything, right? So you start in the head, the ears, the nose, the throat, chest, belly. By the time you guys get down to the genital region, they're already tense, right? By the time you get down to the genital region, they're tense, their cremaster reflexes have kicked in, and a lot of times the testicles have retracted up into the groin. And then when you're examining them, they're even more tense. It's hard to bring them down. And so a lot of times those kids end up in my office. Sometimes they've had an ultrasound and during the ultrasound, also the boys get tense, the testicles move up to the groin. And so when I see one of these kids who's coming to me, typically a little bit older, and now the pediatrician can't find it, typically what I'll do is, first thing I do is have the parent give the child their phone, right? I said to the kid, this is the one time I'm going to tell you, stay on the phone. Everyone's telling you get off the phone. I'm going to tell you, stay on your phone. So have the kid lay down, go on the phone, totally distracts them. And then I always say, for me, I go right for where the action is, right? With the parents there, of course, we examine them. And most of the time, once they relax, if it's truly a retractile testicle, we can bring it down. And for me, the key is, can I get it to come down? Is it loose and not on any tension? And as long as there's no pain, no tension, I have the parent look and say, look, here's the testicle. I show them if you tickle the leg, how it moves up and down. And then I reassure them that 90% of kids, they're going to be fine. Over time, with puberty, the testicle gets bigger, it gets heavier, and 90% of kids aren't going to need anything. But there are those kids that, let's say you've seen at 2, 3, and 4, and now they're 6 or 7, and all of a sudden the testicle's not down anymore. And I think that's a group of boys where when they're little, they're shorter, the testicle reaches nicely. Then as their bodies grow and they get taller and taller, all of a sudden we realize that cord that was fine and adequate to get the testicle into the scrotum when they were 3 and 4 is no longer long enough, where the muscles around the cord are too tight at 6 and 7 because of the change in linear growth. And those are the kids that sometimes end up needing a little surgery to bring it down. So we're always, because a lot of times they come in, pediatrician, told me it was there, now it's not there. And so a lot of times that's the reason I explain to them, like, yeah, the exam can change over time. And so sometimes we do have to intervene and bring it down. And for me, I always give them I always talk about, always my recommendation is surgery. I always mention things like HCG, which I never do, but I know parents are going to read about it. And so I like to hit it off before they start questioning, oh, could we do hormonal therapy? Not a big fan of it. In Europe, they do a little more. And in the past, when people have tried it, it makes the exam a little bit better. And then you're trying to convince yourself that it worked. And then once it wears off, you're right back where you started.
When do you
If you have a child, maybe bring them back just to recheck the testicles, not do a full exam. Do those tricks that I said, have them relax, go on the phone, try to, not be tense. And I think if you've checked them and it's really hard to get that, I think they should be referred. Here's the problem, Herb, that if those kids that have had retractile testicles that have now moved up, let's say that kid doesn't come to us and now he's 10, and now he's 12, now he's 13, and now he's in puberty and the testicle's really not down. The problem is that if we move that down once he's in puberty, those testicles really don't function to make much sperm. They make hormones, but the sperm producing capability, once that testicle's been in the groin in puberty, it's going to be an issue.
and the risk of testicular cancer?
If it's a retractile testicle, probably no greater than the normal child. It's really the testicles that have been undescended at birth. Those are the ones that are at risk of slightly increased risk of testicular cancer. And there's good data to show that if you bring those testicles down by about 2 years of age, that risk really goes down even lower. So retractile testicle, no issues with fertility, as long as they're down at puberty, no issues with cancer. Undescended testicle, one undescended testicle, no issue with fertility. And as long as you bring it down, I'll say by 2, really the risk of a tumor is not 0, but really goes down quite low.
And so you really, the ultrasound is useless. It's better to just go ahead and have the peds urologist take a look and reassure
Yeah.
everybody that it's okay.
It's interesting. So in our guidelines, we really don't talk about using ultrasound. But with that said, I do like to use ultrasound in some instances. I think if it's right, so if you have a kid who has a retractile test, and a lot of times the ultrasound parents want, so that sometimes we're pushed to do things by the parents, whether that's right or wrong. So I'm okay with that. But the truth of the matter is that, yeah, if it's truly a retractile testicle, when they go for the ultrasound, they're going to be tense. It's going to move up into the groin, and the ultrasonographers they're not examining, they're just putting a probe in and say what's in the groin. And so that's why a lot of times we'll reassure them. So I would say, yeah, probably better just send them to us.
So I have a funny story because you said sometimes you just have to do something. I'm so blessed. I get to stay with George, and Deli is also a pediatrician. at their house, right? And so Delia says, could you go in the garage, in the freezer? I just bought these things we're going to use for the barbecue. They're in the freezer and I'm having a panic attack. Man can't find anything. And now I'm a guest and I got to find something in somebody's freezer. So I'm there with the phone, looking at the flashlight, looking and looking. I can't find it. I'm like, I moved everything around. I took all the Omaha steaks out and put them back in. I couldn't find this thing she wanted, some cheese puffs or something. She comes and I'm like, oh my God. You can open that thing. You say, here it is. And she looked everywhere. She says, I thought I put them here. I really went through all the motions because it was what it was going to take to make sure Delia was happy with my work, right? And sometimes that's what you do for parents. A CBC isn't going to do much. It isn't going to be much information. But it's a very low key interventions and expensive, good safety profile. I'll get the CBC, tell them mom the CBC is great. It looks fine.
Correct.
The discussion's over. And yeah, so sometimes you order an ultrasound just to make sure everybody's happy and then you move on. From the perspective of a pediatrician in a children's hospital, everybody with a UTI has reflux and they're going to end up in dialysis because you rotate with a pediatric urologist. And in the old days, they would put the films up on the wall and it was, what grade reflux is this, 3 or 4? I'm not teasing you. I did in Costa Rica, there was a clinic with a pediatric nephrologist.
Yep.
That was only reflux.
Yep.
And it was a whole day clinic and every
Yep.
patient that you saw had reflux. And it was one film after the other. Boom, boom. What grade is it? Because depending on the grade, we're going to have to get the urologist involved. Blah, blah. What is it? How do we think about it today when that's not what really happens in the real world? That happens when you're at the very mecca.
So I actually do, you were talking Costa Rica, I think you mentioned, I actually do every year. I go down to Guatemala with a few of the guys who I trained with in Indiana. And you described it to a T. We work with a pediatric nephrologist and we show up there and we do a clinic on Sunday and probably 30 of those patients, this kid has reflux, this kid has reflux, and you got to fix it, you got to fix it, you got to fix it, you got to fix it. And so it's very interesting the way we treat those kids than how we treat the kids in the States, right? And for a few different reasons. There's no doubt that in a country like Guatemala, where I go, the combination of reflux and boys who are not circumcised, right? Increased risk of infection, right? Those kids are at a much, much greater risk. But here in the States, we've totally changed our approach. And I think for the better, right? So when I was a fellow, we probably did 6 to 8 ureter reimplants a week, every week. Right now, maybe I do 1 ureter reimplant a month, 1 every other month, for several reasons, right? First of all, we're not screening every single child with a UTI with a VCUG. I've worked with people that even people with non-febrile UTIs were getting VCUGs, which is ridiculous because most of those kids, it's just voiding issue, constipation, things like that. Our paradigm has really shifted for a few reasons. I think the first AAP recommendation several years ago basically said with 1 UTI, you don't need to do a VCUG on all those kids. And there's a lot of pushback from urologists, but I fall in the camp where I agree with pediatricians. That's how I practice. I don't really rush to get a VCUG in every child with 1 febrile UTI. The other thing is that we've seen that the rates of scarring, there's a big study called the River Trial, where they randomized kids to antibiotics and no antibiotics, even kids that had reflux. And the rates of UTIs were definitely a bit low when you're on antibiotics, but I'm not sure that it was so huge that it justifies putting everybody on antibiotics. And if you're not going to put everybody on antibiotics, do you need to be as aggressive and be screening for it and over-treating all these kids? We were also doing VCUGs in everybody that had 2 millimeters of in utero hydronephrosis. We were just getting, it was one of the most common tests we were ordering. So I would say our paradigm has really changed to more of education, talking to parents. If I see a kid who's had 1 febrile UTI, I will do an ultrasound because I think that, you had said, Herb, it's a very low risk exam. It gives me a good window into the inside, how the kidney look. I can reassure the parents the kidneys look okay. And then if I see an abnormality, or if I have a child who, let's say, was in the ICU from a febrile UTI and was like very septic, that's a kid I might be aggressive with. If I have a kid that's got multiple medical problems, cardiac problems, other issues that can't really afford another infection, those kids I might be a little more aggressive. But for a healthy 8-month-old that has one febrile UTI and a normal ultrasound, I'll probably hold off on doing a VCUG to see if the child develops another infection. And then if they do, and they have reflux, then it's a much easier discussion, I think, with the parents to say, okay, hey, now you've had 2 infections. Let's look at this VCUG. I throw up the films. I ask them what grade it is. No, I'm kidding. I'm at them. We'll look at the films together. We'll go over the grading. And then we'll talk about the benefits of that. There are some benefits to being on antibiotics for a while. And then it's always a decision. And then what? Because in the past, protocol was if you came to me at 6 months and had a febrile UTI, you went on antibiotics, you got checked every few months with an ultrasound, then you got a VCUG every year. Then if it didn't go away, we would talk about a reimplant. And so now we're immediately, I really try to pull back and I'll put a child on antibiotics for a while. And then if they've done fine, some of these kids will give them a trial off of antibiotics, depending on what the grade of the reflux was. We'll see how they do. Some parents on their own, they'll come back. I'll say, oh, how's Susie doing? She's taking her antibiotic. We stopped the antibiotics 6 months ago. She's been fine. I'm like, great. Mom knows best. And sometimes they do.
Yeah.
Right.
I'll go back to the first lesson in pediatric medicine that I learned from my senior, probably before your time, when we had Bob Brown at RBK Pediatric. Told me pediatric medicine can be summed up as children in general will get better despite what we do to them. Sometimes if you give them a therapy or you provide something, you might make them feel better. You might shorten the duration of the illness for a period of time, make them feel better, maybe make the parents feel better. But the true art of pediatric medicine is in the room of 100 to see the one that's abnormal.
Absolutely.
But I think that talent is being lost. I don't know how many people can do that. Can you walk in a room and smell a problem?
You can, but it's what we were talking about.
Yeah.
Once you only do the Da Vinci robotic surgery and that fails and you haven't done a bunch of open surgery, you're not going to learn it in that minute of pandemonium.
Yeah.
And these younger pediatricians also haven't seen meningitis or haven't seen buccal cellulitis, haven't seen many septic kids, severe pneumonias. And I don't think they know what to do when they actually see somebody that is in real trouble. How about the SMA scans for these kids who have ILOs or the use of procalcitonin as a marker to guide your referral pattern or your own?
Yeah. No, it's a great question. So I don't really use procalcitonin much at all, to be honest, but I do use DMSA scans a fair bit. DMSA scan is it's an injectable agent that will assess for renal scarring. And so many times when I have a child, let's say who's had higher grades of reflux, and we're at that inflection point where they've been on antibiotics for a while, and we want to know, hey, has this reflux been damaging to the kidneys or not? Do I need to do anything about it? That is for me where I'll use the DMSA scan, because the discussion becomes a lot different if I do a DMSA scan that's totally normal. If I have a normal DMSA scan, normal ultrasound, I say to the parents, hey, we've been on antibiotics for a while, no damage to the kidneys, everything looks good, probably fine, versus the child who, let's say, comes back and the kidney that looked okay on ultrasound, maybe was a little bit smaller, has less function, and we see scarring throughout the kidney, and maybe that kid has had repeated infection. So I really like it. I think it's a very powerful tool to help with the management of these kids. People talk about what's called the top-down and the bottom-up approach with dealing with reflux. Right? Bottom-up meaning do VCUGs, see if there is reflux. Top-down, see if there is pyelonephritis, and then use that to guide your need or not for a VCUG. I use it more as I'm having the discussion with the families, really trying to figure out what's the thing to do for their child. For me, very powerful tool. Problem is hard to get the agent. There was a shortage of the agent for a while, so we couldn't even get the agent, but now it seems to be okay with it.
Yeah, and it's much more cumbersome. You got to get an IV, and into younger child, there's got to be a radiology group that does a lot of children as a nurse.
Correct.
All that complicates the testing the process. And then you must do a bunch of circumcision, and only one you hunter. And I agree on this. And I thought I was the only one crazy enough to say it in an exam room. It was always the mother or the grandmother's concern. And I look at him straight in the eye and I go, did you choose a partner based on what their penis looked? They go, of course not. I said, no one does. Maybe he's good looking. You thought he could provide your children with a nice house and he would be a good father. He's someone who's happy, you're happy to hang around with on the weekends. What was below the belt was just inconsequential. You'd already made the decision you wanted to marry this man.
Right.
I assure you, your son's trajectory will be the same, and you're the only one that pays any attention to it. Because if some other guy looks at it as we too much, he's going to get clogged from the nose.
Yes.
And they're like, oh, okay. All right. And I said, so we're done with the conversation. Next, right? How many circumcisions do you have to do a week?
So, right, it's great debate to circumcise or not circumcise, right? And I think the most recent AAP guidelines have said that the benefits of circumcision, if a family wants it, are justified, right? I think the two issues are circumcision, the newborn or the older child, and then the revision circumcisions. For me, I feel it's a parent's thing. Somebody wants to be circumcised. That's their decision. And we make ourselves available to provide that service. We see a lot of kids, a lot of OBs don't want to do circumcision in the hospital anymore. We see a lot of OBs that if the what's called the median raphe, which is the line that runs up the bottom of the penis, if that's off to the side, they tell the parents it's something horribly abnormal, it can't be circumcised, or there's hydroceles, they're afraid to circumcise, or webbing, they're afraid to circumcise. So we get a ton of newborn patients coming to us who want to be circumcised. And we do a lot of them in the office, if the parents want. And I put it, if this is something you want, your decision, I'm happy to do it. So we do a ton of newborn circumcisions in the office. Yeah.
Within the office.
In Michigan, the pediatricians did the circumcision in the nursery, and here at Prince William Hospital too, the belt and clamp. And
Yeah,
I don't
that's
know
what
what
it
I
is.
was doing. I think it's, I regret having done it. But you know, I put the lidocaine and everything, but
Right.
it's still, but when the ones I was mentioning is the ones that they were circumcised, the mom's
Oh,
like,
yeah.
I think the foreskin's a little too big. I'm like,
Yeah. Oh, yeah. So my typical discussion with those parents are, look, if you leave it alone, he's going to be fine. Some of those kids, there are some kids that were circumcised that develop like a secondary phimosis or that really have persistent problems. Typically, I'll start them. I use a ton of Kenalog in my practice, right? It's topical, steroidal. I always tell parents like hydrocortisone. It's very benign. I'm going to say 90% of the time, it resolves any irritation. If there are little adhesions, it resolves it. And then they're fine. We convince them it looks fine and they move on. There are some kids that, driven by the parents, they want them recircumcised or it wasn't adequate, or the kid's really having lots of infections, or they develop skin bridges, or it's constant irritation. And so those will do. But I always put it out to the parents. So this is not something he needs. You can leave it alone, he'll be fine. Do a little topical therapy. If it's really a problem and you're really driven, we could revise it.
Yeah. In the office, I've seen a lot of children that had balanitis, phimosis, irritation, they seem to have these problems, and those are the kids that we send over. It's not like it doesn't exist.
Yeah. No, look, I did a circumcision on a boy 2 Fridays ago. I was actually at Good Sam, and I'd seen him in the office. This was a kid who originally presented to us with difficulty urinating, never circumcised, and probably about 1 to 2% of all non-circumcised boys develop this horrible inflammatory reaction at the tip of the foreskin where it basically closes down. And so he was peeing, and I'm saying gotas, which are drops. He was peeing like little drops. And when we actually did his circumcision, I mean, it was so inflamed, and that inflammatory process, it's like lichen sclerosis of the penis. It actually spreads onto the glands of the head of the penis and can actually affect the meatus. So there are some kids like they really get into trouble. And those are the kids that you really, unfortunately, they just need something done because it can really affects the urethra, the meatus. It really can be a problem. Luckily, most kids don't. Like you guys said, if you leave them alone, they're going to be fine.
So I've asked you the questions from the perspective of a pediatrician. That's what interests me in pediatric urology because you see it all the time.
Yeah.
What is from the pediatric urologist side that we don't send enough to you that we can make a difference? That's part of what you see a lot in your clinics.
Yeah. Yeah. You asked, I'll just pivot back to the typical day, right? So the typical day, in addition to whether I'm in the clinic, whether I'm in the operating room. So in our clinic, we work with several nurse practitioners and PAs that work with us. And we see a lot of kids with voiding, dysfunction, and bedwetting, right? And I think that that's something we love seeing. And before I joined you guys, I was actually listening to a lecture talking about the neurophysiology and neuropathology of voiding, because we see a ton of kids that have really what we call dysfunctional voiding issues. And I think that sometimes, and I think a lot of pediatricians around here send them, but I think a lot of times there's probably a push if they're the bedwetter, if they're having little accents of, oh, it's just they're going to outgrow it, they're going to be fine. And I think when we get those kids, really can provide a very good service to them, because a lot of times in those kids, it's something simple like very aggressive bowel management, right? Like constipation. It's right. I'm sure from your guys' perspective, number one cause of abdominal pain, probably constipation, right?
Yeah.
From our standpoint, number one cause of voiding issues is constipation. But if we're not aggressive enough in treating it and really pushing the limits, the kids are going to continue to have their voiding issues. And we do a lot of stuff working with our nurse practitioners and people. We really get aggressive with these kids with pelvic floor exercises, reteaching them. We do something called biofeedback, which kind of reteaches them how to relax their external sphincters and how to pee in a more coordinated fashion. We do a lot of work with watches to remind the kids to pee, alarms at night for bedwetting. And then we do a lot of aggressive work with medical therapy. And in the past, when a kid came to the old-time pediatric urologist, kid comes who's having trouble urinating, you put them on ditropan or oxybutynin, and that's what it was. It turns out that there's a whole host of medications that we use. And I actually run a conference once a month where probably 50 people from around the country, even some far other countries, we meet to talk about complex kids with voiding issues. And it almost always circles back to kids with anxiety, kids with ADD, kids with other issues, tic disorders, things like that, that can manifest themselves with voiding. And so to me, that's one of the most interesting things that we take care of, because it's so complicated and it just ties into the whole neurophysiology aspect of treatment.
Yeah, I have a patient in the clinic that, I don't know, she's a girl, I don't know how old she is. I never remember how old people are, but her brother has spina bifida. Yeah.
Mhm.
So he's in a wheelchair and he's all battered. And she sits in the toilet and it takes 10 minutes for her to pee. And of course, the mother's out of her mind, like, maybe we need an MRI of her spine too, all of this. And I'm like, maybe she's just stressed.
Right. Well, you're right. You're right. So it's fascinating. So when you're stressed, right, think about and this is what I love dealing with, because all kids that come in, everybody's stressed, right? Everybody's anxious, everyone's stressed. But in a kid like that, who's very stressed, I always say, think about what happens if you had to go speak in front of 1,000 people and you're nervous, right? You release a lot of adrenaline, epinephrine, norepinephrine. What happens to your heart rate? It goes up, right? So that's a physiologic response to stress in your brain. When you're in a constant state of stress, your circulating epinephrine, norepinephrine is higher, and our bladder necks that's where alpha receptors are. And so when you have a high sympathetic tone, it goes to the bladder neck and it causes it to tighten up. And so a lot of times that's why a lot of these kids, maybe your patient, they sit in the toilet for a while because they can't get the bladder neck to relax. So that's where drugs like Slomax, for example, which we use for older men with prostate problems, does nothing to the prostate, but it's an alpha-1, it's an alpha blocker. And it works great in kids like that because it helps to relax the bladder neck and the external sphincter. And
Oh,
so
wow, that's fascinating.
yeah, Yeah,
That's
it's very
fascinating.
cool stuff, right? It all ties in.
Yeah.
We have another I'll just tell you a quick snippet. We have another patient we just took care of, a crazy case. He's got a lot of issues. One of his issues, his spasticity and his tone is so high. And what happens is that he can't relax his bladder neck to when he has to urinate. We've done urodynamics. And so what happens is he pushes so hard that for years, we finally got it. He actually has rectal prolapse. Pushes so hard that he has I'm talking like significant rectal prolapse.
Oh gosh.
So we tried him on Flomax. There's another drug called Rapaflow, a little more specific. We tried it. Nothing worked. And the rectal prolapse was pretty bad. So he saw a pediatric surgeon who said, like, I think I have to do something to rectal prolapse. I said, yeah, when you do that, I'm going to come in at the same time for each out. We put Botox into his external sphincter.
Wow.
And so it basically just causes it to open up. And the hope is that now his rectal prolapse is fixed. And hopefully when he pees, his sphincter will be a little bit more relaxed. He'll still be continent because his bladder neck will work, but he hopefully won't have to push. He's had scopes. There's no blockage. There's no stricture. It's just this physiologic, neuropsychiatric, physiologic thing. Fascinating.
Yeah. And then you gave me PTSD, right? You violated the commandments of the surgeons. You never operate with another surgeon because then you get the patients.
No, nowadays, now we're much more collaborative. No, we do. This one pediatric, we do cloaca repairs together. We do a lot of stuff together.
Because the parents always ask, when they're in there putting the tubes for the kid, could they fix his belly button hernia?
Oh,
Like
yeah.
you're going to get two surgeons to operate on the same patient at the same time. That's just not going to happen.
It's a lot of work, Herb. It's a lot of work, but I'll tell you that we do make it work. We find a way to make it work.
Funny.
And that's actually, to me, and I'm sure you guys feel the same way, right? That's the fun of, not only we get to be doctors, but we get to be pediatric doctors. And to me, it's always a different level. And I see it, and I'm sure your offices are the same, right? Everybody that comes in, it's all about taking care of kids. And I see the way my staff are with kids. It's just such a great level. And I really see it with our patients. You know, I'm sure you guys deal with this, right? Your patients who have special needs, and now they're 18 and they're 19 and they're 20 and they're 21. What do you do with these patients? Because they're used to coming to see you, and your staff are so oriented towards the parents and the kids. I'll tell you what we do. We continue to see them. And I have patients that take care of special needs whose parents are still their primary caregiver and they're in their 30s. I can't turn them over to anybody. What do you guys do for those patients? Do they
Well,
adults?
you
Yeah,
have an
nobody to turn
advantage.
them over to. That's the problem. They don't want to mess around with. It's too complicated.
Right.
And
Yeah,
we
but
see
you
them
have
up
a-
until 26. I have a problem turning over because we do a lot of ADHD evaluations to management. I cannot get a 26-year-old to go to internal medicine
No.
to get their Ritalin. They will not do it. Yeah, you can come in 1 month. We can make a chart and give them 1 month prescription, but you're not going to send them to their neurologist for the meds. They will not see them.
You have an advantage that you trained as a general urologist first.
Correct.
For you, it's not such a breach to keep seeing the kid when they're
That's a
30,
good point,
35
right.
because you have that background. For us, at least for me, I struggle because, as you've mentioned several times, there's certainly a great degree of art to medicine.
Mhm.
And a lot of learning that happens from, I call titrating, not failure, but titrating.
I like
So,
that. Yeah.
so for example, I know how to treat high cholesterol.
Right.
What do? You put them on Lipitor, or that's what you do. And I know even the dose of Lipitor is 10 milligrams. But what I don't know, because I don't do it for every day, is that,
Right.
for example, Crestor is much more effective and it causes a lot less muscle cramping
Right.
and
Right.
it's better tolerated by the patient.
Right.
I don't know that because I don't have 1,000 patients in Lipitor that I switched
Right.
over to
Right.
Crestor. And so I
Right.
feel like I am not giving the patient the advantage of that experience that someone else has because they're seeing adults every day.
Good point. Yeah.
I still get myself over my head because I try to help. And I always say that, yeah, I can manage your cholesterol, but am I the best person for that? Probably not,
Yeah.
because I don't have that feedback look of this medication works better with that patient, and this one causes a lot of leg cramping, and this one causes a lot of GI upset. because I don't do it every day.
Mhm.
So I'm curious what other good stories you have from your visit to Guatemala and Bolivia.
Oh my God. It's just the one thing I would say, it always happens every year when we go down there. So it's mission trips. They're amazing. I feel they're always the same, right? You get down there, it's incredible. Then we do a clinic. We see probably 100+ kids. What always amazes me is that patient number 1 is seen at 7 a.m. Patient number 100 is seen at 7 p.m. and nobody complains.
Oh yeah.
Nobody complains, right? Not a complaint. And people are coming and going. We might run out to get a snack because we're like drained from it. Nobody complains. Thank you. But probably one of the wildest things we see when we go down there is there's a condition. It's called bladder exstrophy, and it's where kids are born with the bladders outside their body. And invariably, it really doesn't affect your health. It just, you reek onto your skin. And invariably, every year we go down there, kids up who's traveled 14 hours from somewhere deep in rural Guatemala and comes in with like towels just tied around them and here to be fixed. And it's always amazing to me, I guess, the patience that people have, the distances they travel, the appreciation, and then the things that we see and that we're able to help them with. And I guess, and the biggest thing we've changed over the years, we've been going probably 17 years now. And we've really, by going the same place every year, we have such a great relationship with the nephrologists, the pediatric surgeons, urologists down there, and through technology, right? Emails and WebEx and media, that like the care is so much better, right? Like they have a question, they text me, hey, this kid's here. What do I do with this tube? Let me send you a picture of this. Here's what's going on. And really the change has been awesome.
And then when you're down there, do you have a Da Vinci robot no? So you get to practice the open surgery techniques.
Oh yeah. I took my daughter with me. My daughter's a first-year med student. Last May, we went down there. And the first case was an 11-year-old boy. He had bilateral UPJ obstructions. Okay, so bilateral UPJ obstructions had been managed for a year with tubes hanging out his back. Okay, that's what was managed for a year. Infection. So the approach was literally 2 subcostal incisions, 2 giant incisions. So the first case, said to my daughter, scrub with us. I did it with one of the pediatric surgeons. They're like, put your hand in here. Her hand's on the liver. She's holding the bowel. And it was great. Yeah, back home, this would be teeny tinies. It doesn't exist there, but the kid got a great operation. Tubes came out and bigger scar, a little bit longer recovery. But in the end, the result was fantastic.
I'm curious, is she going to go into urology or she doesn't know yet?
So great question. I wish she would go into pediatric urology, but you know what she wants to do? Pediatric surgery.
Yeah, close enough.
She's really
Close enough.
Yeah, it's close. And I said to her, here's what I'd love. You'll become a pediatric surgeon in about 15 years. I'll know when my time has come and I'll come in and I'll be your first assistant. Right? How great would that be? I'll just stand there. I'll hold the camera for you. I'll retract for you. I'll be the best first assistant you ever had.
Yeah,
That's
let me
so
give you some
awesome.
advice with her because my
Yes.
son's a 3rd-year medical student.
Oh, nice.
And everybody said, oh, you should go into pediatrics. You want to do surgery, you want to do ortho, you want to do everything but pediatric. He rotated in our office and he saw, we don't just do well baby checks and functional murmurs. We do like real medicine.
Yeah.
He's going into pediatric.
I love it.
And his girlfriend.
I love it. I love it.
Into peds. Pediatrics is a great thing. We see everything, but you have to want to see it. You have to be accessible.
Right.
Yeah.
And
Yeah.
but you guys also, like you said, you practice, right? You're not sending every kid. You're managing these kids. You're working them. You're the place parents feel like I'm here.
Yeah.
Figure out what's wrong.
Correct.
Like, oh, they got a cough. Go to the ER. You're doing all that stuff there and treating them and taking care of them. It's a difference.
Yeah, that culture at our practice was established way back in 1958 by Dr. Reichman in his garage.
It's
He always
amazing.
told us you have to have access to care. You have to care about the patient, fix their problem, and if they need to go somewhere, send them somewhere. And don't just give them a piece of paper, go to the urologist. Call the urologist, call the specialist, run the case by them. More of a relationship kind of a thing, not just here, push a button and go.
Yeah.
And look, George, that's what patients want, right? Like I always say
Sure.
to I think it of myself. I say to my colleagues and my staff, I'm like, patients want an experience. They don't want to they want to know what's going on, but they want to feel taken care of. They want to know they can come to you. They want to know you're available, you're accessible, right? That's the key, right?
Yeah,
And we're
I
lucky
was
we get
taught by Dr. Reichman that like we get these kids that have leukemia or more devastating problems. So they end up going to a lot of our hematology. Hematology goes over to you guys with Dr. Simek, that crew.
Yeah.
Yeah, we don't manage it anymore. They go somewhere else, Northwell or something. Yeah, we don't get involved, but we always call and check in. How you doing? What's going on?
Yeah.
And they appreciate that.
But it's not,
Like,
it's not only the relationship with the kids and the parents. And this is missing, and this is Epic's fault. I used to know adult pulmonary guys, the cardiologists, the pediatric cardiologists, the pediatric pulmonary guy, the GI, the surgeons. And you said, George, if it's a call, this kid's got this is what I've done. I'm going to send the records over. They're going to call your office for an appointment. And then you would shoot the breeze. How's your daughter? What year is she in? Is she going to do a rotation with us? And that's sorely missing. I think that's part of why physicians are not happy and they want to leave. There's no joy.
I'll tell you, that's why every time I give a talk to a group of pediatricians, or if we happen to have some of these patient reps that go out to meet pediatricians and talk about, I always say, give my cell number. What do you mean give it? I put it up. If they give a talk, put it up. Because people, it's so easy. George, if you're seeing a kid and you have a cry, shoot me a text. Send me a picture of it. Is this a concern, not a concern? And it takes the stress off of you. Parents feel relieved. And I feel relieved. I'm like, spoke, 2 seconds, done. It's either something we got to deal with or not. And it just really, I think, helps with the care. Yeah, I agree. The Epic, makes it a little colder, but the cell phone, I get texts all day long. I love it. The best.
Yeah, I do it used to be you call them up, talk to the secretary. They come, they'd interrupt you. You get on the phone, I'd ask you your question. That takes time and it interrupts you. I have a bunch of specialists on my cell phone. I'll say, hey, I send a text. Can you give me a call? I have a question. Because I don't know if you're in the operating room or you're in a consult, something, and then they'll call back. They always call back. Hey, what's going on? What can I do? Convenience. Then I'll put the patient back with the answer later.
Yeah.
That's what patients want.
That's
So I
what
give patients, I actually, believe it or not, give patients my email address, not my Gmail, but like I have a work email. And people are like, oh my God, you must get a million emails. No, people are super respectful. It's like they know it. They know they have you if they need you. And if they email, I respond. It's really never a big deal.
You will never, like when I'm on call, I'll call back from my cell phone, but I don't use this block-in technique of or covering up my phone. I've had one patient, my entire career, call me directly.
Yeah.
And then I said, listen, this is my personal cell phone. Please call the office and they'll get me. They never did it again after that.
Yep.
Nobody ever does that. Most patients are respectful of us.
Totally respectful. I agree.
And so I have an interesting question. You've talked several times today, WebEx, texting, email, all tools to better communicate with other physicians and maybe even your patient. But you avoid social media.
So it's funny. So funny because in my family, they have a joke. I joke with them because they're all on Instagram and TikTok. I'm like, guys, I do no social media. And they always make fun of, oh, you're so special. I'm so busy during the day. Whether it's emailing people or texting people or working or communicating. And whenever I go and I get sucked into like Instagram, I just feel like my brain goes numb and I'm looking through things I don't really care about. And so for me, yeah, I don't, it's so funny you asked that, Herb, because I don't do any social, I don't know. I don't know that I have capacity in my wavelength to do it.
Well, after this podcast, I promise you, you're going to be all over social media, especially on LinkedIn.
Fair enough.
Yeah.
I know. I probably should, right? I probably need to step up my game.
Spencer will show you. Spencer will show you close.
The only reason I think that social media is important, and I would do for what I do, Instagram is important because who has children? It's young women. And young women are particularly pulled into Instagram for whatever reason. But it does build community. So your experience is how many thousands of kids you're seeing that you're,
Yeah.
taking care of.
Sure.
That community would always be there to celebrate wins. And I think that's where it can be impactful. Somebody that you operated on when they were 3 years old and they graduated from college and they're
Right.
going to go into research about robotic surgery.
Right.
That would be, I think, very nice.
Right. No, it's true. Yeah.
But you're right. It is a time suck. So you have to have an assistant manage that property so that you're just getting the good stuff and not
Right.
being sucked into all the nonsense. I want to be respectful of your time, but I have one more question for you, and
Yeah.
is why haven't I asked you, do you think it's important for our community to hear?
I think we've really covered I think we've covered a lot of nice topics. I think for the community, I guess pediatricians to hear, I think the biggest thing for me that I saw, and we just talked about it a few minutes ago, is just being available for our colleagues, being available for our patients, and just the importance, I think, of taking the time to educate our patients and taking the time to make every patient feel special, give every patient that experience that they walk out of the office and they feel that, you know what, this doctor really cared about me. They took the time, they sat with me, they listened to me. And whether it's something bad and they're going to fix, I feel like I'm in good hands. And whether it's something that I don't really need to worry about, whew, I feel better. I don't have to worry about it. And so that's really how I try to approach each day and day in the life. That's really how I try to approach each interaction.
Thank you very much for coming on the show. It was a delightful time with you.
It
Hope
was
to
great.
meet you in person soon.
Yeah,
was
thank you
great.
thanks so much for having me. You have to send me a link how to access it.
Send it to your email. Thank you very much. And if you
No,
have
it's
other
great.
colleagues, if you have other colleagues in different specialties, put us in touch.
Okay.
Here, a day in the life of a neurologist, a day of a life in a neuro. I'm actually going to get a neurosurgeon. We've already done GI, pulmonary.
Have you done ENT yet? I have a good ENT person.
ENT we did not do yet.
Okay.
That's
We
good.
have a really great, she's now been in practice 3 years, the Horror Talk. I don't know if you know her, George.
No.
I'll put you guys in touch. But Herb, thanks for doing this.